Device-related infection is one of the most serious complications of CIED therapy and is associated with significant mortality and morbidity. Definitions of cardiac device infections. Localized infection may be either superficial incisional infections or isolated pocket infections limited to the hardware in the pocket. And systemic CIED infections may occur with or without pocket infection and with or without visible visitations on the tricuspid and pulmonary valves or passing lips. Cardiovascular implanted device-related infective endocarditis is defined as the evidence of CIED infection with clinical signs of pocket infection and or imaging findings, which fulfill the criteria of valvular infective endocarditis. Pocket infection accounts for 36 to 64% of CIED infections. What American Heart Association clinical definition of cardiovascular implantable cardiac devices says. They defined in pocket infection, lead or valvular infection. They defined in pre-extraction criteria and post-extraction criteria. In pre-extraction criteria, pocket infection, device erosion through skin, purulent pictures from the pocket, flatulence, sinus tract, with or without positive blood culture, or FDG PET CT with abnormal activity at pocket or general site. In valvular infection, pre-extraction includes 2 or more positive cultures for Staphylococcus aureus or the same species of coagulase-negative staphylococci with no alternative source. And TE findings consist with echo density in the device lead or visitations of the heart valve, or PET CT, FDG PET CT with abnormal heterogeneous activity along leads or native or prosthetic heart valves. In case of post-extraction, pocket infection is intraoperative findings consistent with infection, including purulence with genital pocket site or inflection, or positive device tissue, sonicate fluid cultures, positive broad spectrum PCR sequencing, or metagenomic next generation sequencing with intraoperative findings consistent with infection. And in case of lead and valvular infection, post-extraction, positive device tissue, sonicate fluid, broad range PCR sequencing, metagenomic next generation sequencing with the same organism isolated from the blood cultures. This is one of my case with genital infection. He came to me for management. Pathophysiology and microbiology. Infection usually results from bacterial flora from the patient's skin or seeding with higher bacteremia from a distant focus is less frequent. The most frequent agents identified with bacteremia and CIED infection are Staphylococcus aureus or coagulase-negative staphylococci. Other positive organisms are Enterococcus species, beta-hemolytic streptococci, oral streptococci group, Cutibacterium, acnes or Corynebacterium species. More rarely, systemic infection is caused by gram-negative, mainly Pseudomonas aeruginosa or Serratia marcinensis, or polymicrobial agent, whereas systemic fungal infection, Candida and Aspergillus infections are exceptional. This is one of the findings what cultures yield. In 36% cases, there is negative culture, and 30% there is coagulase-negative Staphylococcus. Risk factors. Risk factors may be divided into patient-related, procedure-related, and device-related factors. The PEDIT study randomized 19,603 patients undergoing CIED implantation to conventional treatment, pre-procedural cefazolin infusion versus different regimens of incremental treatment. The primary outcome was 1 year hospitalization for device infection, which was not significantly different between groups. Hematoma is a major contributor to risk infection, and all possible measures should be taken to avoid this complication. Another major risk factor is a revision of the reopening of the pocket. It is generally recommended to wash the pocket with antibiotics and antibiotic mesh envelope, which locally release minocycline and rifampin for a minimum of 7 days, usually absorbed within 9 weeks, may however be useful to reduce risk of infection in selected patients. Diagnosis. Clinical presentation of CIED associated infectibilities is similar to valvular infective endocarditis, with patients frequently presenting with fever, chills, embolic events, signs of pocket infection, swelling, tenderness, erythema, purulent discharge, etc. may or may not be present. The body data positive blood culture in a CIED recipient represent underlying device infection depends on the organism type and duration of bacteremia. Transthoracic echocardiography, esophageal echocardiography are both recommended in case of suspected CIED-related infective endocarditis. Diagnosis of CIED-related endocarditis by FDG SPECT-CT has good sensitivity and specificity. White blood cell SPECT-CT has also been used to diagnose CIED infection but has limited availability. Prophylaxis. Antibiotic prophylaxis to prevent CIED-related infections before interventions such as dental, respiratory, gastrointestinal, and genital reposition is not warranted as the risk is very low. Prevention of CIED infection at implantation hinges upon the careful planning, preoperative antibiotic prophylaxis, coordination modified risk factors, hygienic surgical environment and technique, ancillary measures in case of increased risk, as for example, antibacterial envelope, proper postoperative care. Vancomycin, when are used. Treatment of CIED infection combined with initial empirical antibiotics have been detected at MRSA and gram-negative bacteria while awaiting identification of the pathogen. In exceptional cases where complete device removal is not possible, IV antibiotics for 4 to 6 weeks may be individualized long-term suppressive oral therapy. Complete device CIED removal is recommended to all patients with confirmed infection of the leads. Complete CIED extraction should also be considered in case of valvular infection without defect.
Sorry. The slides. We cannot hear you. Neither the slides. Hello, Sir Basman. We cannot hear you.
Let me see. Can you hear me?
Yes, we can now.
Yes, yes. Complete devices should be considered even in the absence of hesitations in the setting of persistent relapsing gram-positive bacteremia or fungemia after a course of appropriate antibiotic therapy if there is no other identifiable source. Device extraction continued. Lead extraction should be performed without delay, as this has been shown to be associated with improved outcomes. Percutaneous rather than surgical extraction is the preferred procedure, but requires specialist tools and should be performed in centers with expertise. Large vessels may be aspirated percutaneously before lead extraction to reduce the risk of embolization, as surgical risk extraction should be considered in case of large vessels, as for example, more than 20 millimeter. If aspiration is not available or is unsuccessful, or valvular surgery is required. Device reimplantation. The indication for implant should always be carefully evaluated and no part of the removed CIED should be reimplanted. Reimplantation should be performed at a site distant from that of the previous generator and should be done after 72 hours of negative culture after extraction in the absence of ghost. After 2 weeks in negative bulk if agitations are visualized. Device implantation for patients high risk of sudden cut is very different. That is the bridging for implantation. Are pacemaker dependent patients on active fixation lead may be introduced via the internal jugular vein and to external pacemaker for up to 4 to 6 weeks. Alternative devices such as leaded pacemaker or superside may be implanted in selected patients if the risk of new infection is deemed high. The recommendation is the same what I told, the same. It is by ESC 2023. This is the same ESC. Now, this is a chart summarization of prevention, or summarization of CIED infection, that is prevention, diagnosis, and management. What I told, adherence to the prevention, adherence to the standard infection prevention preventive measures. Single dose of prophylactic cefazolin, antibacterial envelope for high-risk patients, and hematoma prevention. These are the methods, these are the taken care of for prevention of CIED infections. Diagnosis, physical examination, TEE, PET-CT, or device sonifications and molecular techniques to enhance microbial detection. And management, we have told it, they consider subcutaneous ICD or leadless pacemaker in high-risk patients, new CIED implant once pocket is adequately deprived and blood cultures are negative, chronic antibacterial suppression for non-extraction candidates, and complete CIED removal. This is a paper that had said regional antibacterial for implanted cardiovascular electron device infections. Patients' present guidelines endorse complete removal of cardiovascular implantable devices, including extraction of all intracardiac leads, and not only for systemic infection, but also for localized pocket infection. So the authors evaluated the efficacy of delivering continuous in situ targeted ultra-high concentration of antibiotics into the infected subcutaneous device pocket, avoiding the need for device extraction. What they conclude, CIED is a safe and effective alternative for patients with pocket infection who are unsuitable or unwilling to undergo extractions. Take-home message: strict maintenance of sterilization before, during, and after the procedures, choice of prophylactic antibiotic according to local recommendation, patient education for maintenance of hygiene, regular routine check-up during follow-up, early detection of any sign of infection in the pocket, ensure good control of comorbidities. But you know, I am from Bangladesh, and the people has to pay from their own pocket for any device. Sometimes we reimplant the device after proper sterilization with ethylene. And I myself used to take the lead extraction is very important. I usually do the lead extraction first, then the implant the same generator with new leads in the same site after 2-3 days, and 3 only at least 1 or 2 post procedure culture negative.